So this morning is going to be more theory of functioning with some videotapes. And this afternoon we'll focus more on intervention. So it is quite didactic this morning, but hopefully it'll make sense to you. So most individuals seek therapy for emotional difficulties. So especially when I came from an engineer into psychology and psychotherapy, it seemed crazy to me. No one was talking about emotion, but people come with emotional difficulties, and it's taken 30, 40 years for the field to get to that point, right? People are usually feeling bad about themselves, in emotional distress, in relationships or in their life. And they have difficulties dealing with painful core emotions, particularly, we have found, and you'll see me emphasize, fear, shame, and sadness. You'll also notice anger is not there as a core painful emotion. It is a troublesome emotion, but it's more people are wanting to regulate their emotions like panic and rage. But I'm going to say these are secondary symptoms. But difficulties with emotion lie at the core of most mental health disorders according to the diagnostic classifications. But there's a growing increase in the field in the focus on emotions and seeing them as underlying problems in dysfunction. Various therapeutic interventions have been developed over the years to promote therapeutic change in affective disorders and in all disorders. But they've focused on cognitive processes, interpersonal processes, neurobiological processes, motivational processes, but not on emotion. Emotion has been treated as the dependent variable. Something else causes it and it changes. And I've tried to change the focus to see it as the independent variable or as a thing that can change. So we need to target emotion in all the disorders. Emotion-focused therapy is a neo-humanistic, integrative, research, evidence-based approach to therapy. It's grounded in contemporary emotion theory, in neuroscientific research, and psychotherapy research on emotional function. So the important thing is, I see emotion as the fundamental datum of human experience. It's what comes first. Right? I walk into the room, I see you, immediately I have some kind of emotional activation in me, right? And then things carry on from that. In addition to that, emotions, from about the 90s onwards, up till then, emotion was something to be got rid of, something that was bad, something dysfunctional, and still is viewed as something to be regulated. But emotions actually are adaptive. They provide survival action tendencies. Fear leads me to run away for safety. Sadness leads me to cry out for contact. So they provide survival action tendencies that are innately adaptive. We see adaptive emotions also as helping to change dreaded, painful emotions. But we also recognize the importance of the construction of narrative meaning. My whole career or history can be seen as a tension or conflict between being a rational, mathematically oriented engineer and being a heartfelt, empathic, emotional person. And those two parts sorted themselves out by developing a theory. So the perspective this is sort of a global overview, the perspective I'm going to offer is a transdiagnostic perspective. Humanistic therapy started off with, we do this with people, we don't diagnose them. Then the differential treatment paradigm developed, particularly driven by CBT or used by CBT as what treatment for what disorder, but that's kind of collapsed. And there's a return back to a transdiagnostic perspective. It doesn't matter what your disorder is. We've got to work on the change processes, and they're not unique to a particular disorder. So this suggests the same treatment with slight variations applicable across all disorders. And the aim is to correct emotional processing difficulties. Mm-hmm. So it doesn't matter if you've got anxiety, depression, PTSD. We're trying to treat the emotional processing difficulty, and we use basically the same treatment. And the assumption is when people are able to process their emotions, they won't have disorders. So the proposal, in 1986, I wrote a paper called Change Process Research, and as Juliet said, I've always been focused on how do people change. Well, there's been a revital, that was then overridden by the differential treatment paradigm, but there's a return now to a more process-based view of therapy. Something's wrong with the current evidence-based approach of differential treatment. Effect sizes haven't risen over the last 50 years or 40 years of its existence. We're not treating people any better than we were 40 years ago. And we're beginning to see the end of randomized controlled trials as the gold standard and the beginning of a new view. And this is a revitalization of a process-based change approach to treatment. Evidence-based care and the randomized clinical trial came from a medical model of different treatments for different psychiatric problems. But this biomedicalization of human suffering has not paid off in a way that was hoped for. Treatment protocols for different disorders or maladies have proliferated. There's this treatment for this, for social anxiety, for PTSD, for this, but this is unwieldy. It's difficult for therapists to cope with learning this manual for this and this manual for that, and it doesn't really fit the needs of the individual because it's not paying attention to what's this person's problem. Change process therapy involves taking a much more individual, case-based approach focused on understanding the process of change for this person. So instead of finding the best treatment for this disorder, the focus should move to how to help improve the client's processing of core painful emotions underlying the symptomatic presentation. What underlies your depression? What underlies your anxiety? What's the core underlying processing problem? And so treatment should be based on a case formulation, not a diagnosis, and a formulation that incorporates how to work with this client's core emotion. So we approach how to help a depressed client transform their emotional pain. Is their emotional pain the sadness of lonely abandonment, feeling unloved? Is it the shame of worthlessness, of feeling invalid and defective and incompetent? Or how do we help an anxious client overcome the shame underlying their social anxiety? Or reduce their basic attachment insecurity? So notice, if you're depressed or you're anxious, it doesn't matter. We're looking for what's the core underlying emotional difficulty and how to help you with that. And it can be exactly the same or different depending on your disorder, presenting disorder. This approach will more effectively address what clients really need and what therapists really do. So I'm going to present a unified emotion perspective, right? Saying that a treatment that treats emotional processing difficulties will be applicable across disorders and will correct emotional processing by the following kind of process, which I will elaborate on today. First, you need to arrive at emotion. You need to approach it, become aware of emotion, allow emotion, tolerate emotion, regulate it when necessary, accept it, and symbolize it. But notice it's not just, there's a lot of, and always has been since the beginning of the humanistic therapy, that somehow accepting your feeling is the path to change. Now with ACT, for example, acceptance and commitment. But acceptance is not enough. We also need change. So it's a combination of acceptance plus change. So we help people arrive at emotions, but then we also help them leave emotions by transformation. If I take you to your core shame or to your core fear, it's good to accept it because then you can work with it, but just accepting it isn't enough. You're still left with shame or with fear or with sadness. So we want to transform that which is maladaptive, and we do that by activating alternate adaptive emotional responses. And I will go into that. But we also focus on construction of new meaning. So when I was 25 years old and entered the field, meaning was the central issue for me in my personal life and theoretically. Meaning is what's important, meaning is what determines. But over time I came to see that it's not that meaning, which is the CBT claim, produces emotion. It's that we make meaning from our emotions. So it's a different role of meaning, right? We bring cognition to bear on emotion to make sense of it. My life is a continual process of making sense of what I feel. We ask each other at breakfast, how was your night? Where are you now? We're organizing where we are, where we find ourselves in our embodied sense of the present, right? So constructing, and as human beings, we're narrative meaning makers. So we're always making up stories, so to speak, to capture where we are and what's going on in our lives. But it's important to see that emotions determine narrative. Narratives don't determine emotion. Or narrative helps us make sense of our emotions, right? So we've developed measures of different emotion types. Well, I'll go into that. Primary, secondary, instrumental emotion. We've developed measures of productive emotional processing. It's one thing to arouse emotion, it's another thing to process it productively. We've also specified that emotion processing occurs in steps, in sequences, and that it's going through this sequence of steps that leads to transformation of core emotion. So it's not just feel your sadness or feel your fear. It's also go through a series of steps, which I'll talk about, right? So both productive processing and emotion transformation have shown to be good predictors of therapeutic outcome. So that's a sort of global introduction. So now we'll look at the EFT therapy process. And again, it'll be a brief introduction at first. So firstly, it combines following and leading, or following and guiding. So there's an interpersonal style. Prior to this, in my view, some therapies were non-directive and following, other therapies were directive, guiding, manual guided. So I don't know, it was either or. It's much more complex to have a relationship style that combines both. But then you have complex questions like, when do I follow? When do I lead? When do I move from leading to following? When do I move from following to leading, and so on? But that captures the reality of really what's going on between two people. So we're going to have following and guiding. The following aspect first involves the therapist being present and empathically attuned to affect, right? Or also to meaning. But this is a way of being rather than a way of doing. Right? This is like being present. It's not an easy thing. It's something that develops in training people. We're promoting that in graduate school, you should be trained in being present. With the popularity of meditation and so on, it's made this much more palatable to people. Being present isn't the same as mindfulness meditation, but they're related, right? But so it's a way of being. So I have to be present in the room, in the moment. Being present, we've developed a measure of being present, involves basically being completely in the moment, bringing one's whole self into the encounter with the client, being grounded in one's own body. There's something about getting information from your body, but also attending to the verbal and non-verbal aspects of what the client is doing. Right? So when I'm in a room and there's a sunbeam that's shining through the window between you and me, and a speck of dust drops between us, I see that speck of dust because I'm present to what's happening. I'm not thinking, I'm not planning, I'm not trying to get you somewhere. I'm trying to be here with you now. And that will, I'll be open and like absorbing. Younger people probably don't know what a blotting paper is anymore. You blotted the ink, right? You absorb it. So you're absorbing it. So I see when your eye films over before you cry. I see your mouth twitch. I see you, your fingers stroking yourself and so on, because I'm present. And I don't clutter my head with thinking. Right? So our first thing is we want to be present and empathically attuned to affect. What are you feeling right now in this moment? But next is a form of doing, which is being empathically responsive. I have young students who say, I'm really with my client, I'm really present, but they're silent, right? So they're not communicating. So that's a form of doing. So now we're going to communicate the relational attitudes specified by Rogers of empathy, respect, and genuineness, we can call them. And that's a form of doing, right? But now we go to, in addition to this, we also said in academic terms, we facilitate particular modes of emotional processing and meaning creation at particular times. So we're going to do different things at different times to help you process your emotion in a different way. The most characteristic is there's one coding system that we use, the narrative process coding system, in which there are just 3 simple codes, right? Are you talking in an external narrative? That's what most clients come in and talk about. They talk about what happened. This is what happened and this is what happened. Then there's a reflexive narrative. What does it mean? If you're psychoanalytically informed, you go to what does it mean? But one of the interesting observations I've made all around the world, when people are in pain, they go to why. And they spend their time in the why. Why was it? Why did you kill yourself? Why was you abused me? Why did you leave me? Why? And it's actually a way of distancing from emotion, of not feeling what it feels like. And somewhere I'll talk about breaking the why down into I'm angry that this happened and I'm sad that this happened. But people move to meaning. We're all brought up in a meaning culture. We're encouraged to think, to conceptualize, to make meaning. I certainly thought meaning was the most important thing when I was younger. So people move to making meaning. So the client can be talking about what happened, external narrative. What does it mean? Reflexive narrative. Brunner, a leading child psychologist, developed a narrative process coding, and he had those two codes. I looked at it and I said, but what about feeling, right? There's another narrative. There's an internal landscape, not the landscape of action, what happened, not the landscape of meaning, what does it mean, but the landscape of feeling, an internal narrative, right? So if you're talking to me in an external narrative about what happened, if I respond to you in the landscape of feeling, you're 8 times more likely, we've shown in research, to shift, to start talking about what you're feeling from what it means or what happened, right? So we're guiding people's processing to the internal, to the landscape of feeling. We're doing many other things to guide you, but you know, if I say to you that I imagine that just left you feeling like you want to shrink up into a ball and hide, I'm guiding your processing, not the content, but the way you are talking about. And we want to bring you to be able to activate or arouse emotion. So we're going to facilitate particular modes of processing at particular times. So on the one hand, I'm guiding you moment by moment. There's a gentle, consistent pressure to the internal. Like what's it like inside? What are you feeling? What are you aware of? But then, and this has become a hallmark of EFT, we started defining in-session experiential problem states. And they're markers, we could refer to them as, they're markers of particular processing difficulties. The most simple one is that I'm self-critical. There's a self-critical marker. I'm so stupid. I'm not a good enough mother. I'm not a good enough wife. I'm not a good enough parent. That's a self-critical state. It's quite different to, I just feel, I don't know what I really feel. That's a vague, unclear felt sense. It's not a self-critical state. Or my father, he's never been there for me. He never came to my wedding. He left me sitting on the doorstep when I was 5 years old on my birthday party. That's an unresolved bad feeling towards a significant other or unfinished business. So we're listening for what markers emerge. Markers are also indicated, they need to have an aliveness indicator. It's not just, oh, I'm really talking to you, but I want a glass of water, and I really need the glass of water, but I'm in conflict. Because, I mean, I'm not doing it well. But that's not an alive conflict. But if I say, I'm dying for some water, but I just shouldn't, in front of people, do anything that satisfying my needs, I'm bad for doing that, has an aliveness indicator of struggle. It's not, oh, my father has always ignored me. It's like, my father really, he never came to my wedding. So it's got to be in a live state. If I want to enter into your internal world, I need to pick moments of what's alive for you, not what's conceptual. We often have people say, people know what their difficulty is, they just don't feel it, right? And we know that we're ashamed or that we're anxious, but that's different to being anxious, right? So I'm going to guide you. When I hear a marker that's alive, I'm going to use a particular kind of intervention. And there'll be different interventions and different processes, right?